I think we can still, get the gist of sports neurology across. It's an exciting field. I am fellowship trained, and it really is a new field as of 2012. So it's probably one of the newer subspecialties in neurology. And to me, it always makes sense, to have a brain injury. This is a brain injury type of field primarily, and, we're brain doctors. So it really makes sense for a neurologist to be involved in sports, particularly contact sports, combat sports. So I do have a lot of experience with live event coverage as well. So we'll talk a lot about that today too. But this is going to be very interactive. I have a bunch of videos of different, head injuries happening and things like that. And so, we'll go through a few cases to talk about as we kind of go. So feel free to chime in or, write something in the chat. I haven't really mastered how to do everything at once, so so I'm working on it. But if there's something that comes up, Genevieve, you'll just let me know too, right?
Yes, sounds good. And at the end, you can always unshare your screen and go through the questions if you need to.
Okay, perfect. So either way, we'll get to everybody. Okay, great. So without further ado, we'll really start off with what is sports neurology. So again, it's one of the newer neurologic subspecialties. There is obviously a lot of overlap with neurology and sports, right? So we really manage neurologic conditions that occur in athletes who, because of their sport, need to perform highly. And not just athletes, I like to also kind of talk about how we're also involved in like musicians and CEOs and executives, people who really need to perform highly either in their workplace or just really like to be active. Maybe they're marathon runners, maybe they're, they do a ton of CrossFit, different competitions like that, so we kind of see the gamut in that realm. And, what this first portion really means is, we manage migraines, epilepsy, MS, any neurologic condition, which would have, of course, occurs in the general population, will also occur in athletes. And, it's really managing them under the conditions of their sport. So things like, under dehydration, under travel schedules, sleep deprivation, all of those, extreme temperatures, all of that these athletes really go under can certainly affect their neurologic condition. Then the next point is really neurologic injuries that occur as a result of their sport or as a result of their job. So, for example, concussion is probably the #1 thing that we treat, but also brachial plexus injuries or stretch injuries of the peripheral nerves, muscle-related conditions, things like that really occur that are neurologic based, but because of their sport or because of an injury while in their sport or while in their everyday life that occur. And how do we treat that in terms of how do we get them back to their sport and back to that risk of taking another head injury, for example. And then also there's always overlap, as in medical school, from neurologic diseases and the relationship with physical activity. So physical activity is like the #1 thing that we promote in neurology to help manage things like MS, migraines. These are things, Parkinson's. We're always pushing people to be more active because we know that, it really helps from a neurologic standpoint with their conditions. Dementia, is another example. So these are the types of things that we always want to promote regardless in neurology, and certainly in sports, there's that extra overlap. So what does a sports neurologist do? We really diagnose and treat different neurologic conditions that occur in athletes or people who like to be physically active or have to be high functioning in their jobs. We also guide any decisions for retirement from sports. So when is it time to, stop playing their sports, stop boxing, stop playing football, that kind of thing. It's not a cut and dry decision, of course. I mean, these are people's livelihoods. Even in college level, there some patients say, you know, I just don't really want the risk of a head injury again, you know, or they're not tolerating their sport because of symptoms from head injuries. So it's a complicated decision. It's not just a cut and dry, oh, you've had 3 concussions, you're done. You know, that's really not what we do. We really have to think about it and, you know, do some imaging and work it up and get some neuropsychology testing and, you know, see how we can maximize them. And then at that place, you know, we'll make decisions kind of together with the patient. So we also want to help patients recover from their concussion and from post-concussion syndrome, of course, you know, which can be difficult, but, you know, and they're in high stress kind of jobs, high stress lifestyles. So, you know, slowing down from this, what we kind of call an invisible injury, you know, is really difficult. So there's definitely a lot of neurology at the basis of it, because of course it's related to the brain, but you know, a lot of psychiatry too, and a lot of the psychology part of it, and dealing with a lot of moving parts. So this population is like really, it's really fun to me for that reason, but very complicated. And that kind of goes along with the next point, which is that we have to really collaborate on the care of these athletes with their sort of entourage. So they have an agent, they have a general manager, they have a coach, they have athletic trainers, other physicians, family members, you know, because sometimes, you know, this athlete playing, you know, has a lot of ripple effects, right? So it affects the livelihood of multiple people. And, you know, there's a lot of people that are invested in that. And from my standpoint, you know, I don't care about that. I just care about the athlete and their health and what's best for them. But it may take us having these meetings together to try and get everybody on the same page and helping the athlete manage some of that. So it's very dynamic in that way, and it's pretty unique from a lot of other fields of neurology, absolutely. And then of course, the last point is tons of clinical research opportunities. You know, there's always stuff being done. You know, on a weekly basis, there's new literature coming out in concussion and recovery and things like that. So, you know, there's always a role for that as well in our field. So the settings and roles of the sports neurologist. So typical settings in terms of live, you know, event coverage is we are ringside or cage side if you're talking about MMA. We are slope side. We do things with the ski and snowboard teams. You know, a lot of times there's always a neurologist involved in sports. Sidelines, of course, in football, either college level or, you know, even youth level, we have involvement as well. And I like to be involved at all levels. So, you know, I am treating patients that are age 6 and up, even as an adult neurologist, because of my training for sports. And then of course the other setting is we're outpatient. We're not typically an inpatient subspecialty, but I have, you know, privileges at hospitals in order to do a consult. So let's say one of my patients gets injured or I'm working a live event. I need to be able to get to the hospital with that athlete to help, you know, mitigate getting through, you know, to CAT scan right away and being an advocate for that patient. So I will be in the hospital setting for those purposes. And then the roles really are, this is, you know, very short list, but it's really limitless. I mean, you can really make the field what you want it to be. Some of the options that people don't always think about is that you can be a team physician, that's one thing, or you can be a consultant to a team physician or a team, you know, as an outsider. So you don't necessarily have to travel with the team, kind of is what that means. Or you can really be a consultant to a venue. So for what I do, I'm in Connecticut, so we have Mohegan Sun Casino and Foxwoods Casino, and they put on a lot of sporting events. And so I cover a lot of their sports and entertainment events. So for the venue, kind of from that aspect. So regardless of what's there, you know, we're kind of on call for those things. Definitely their boxing events and MMA events. And then, you know, other things really are for roles is, you know, certainly we can also be just an independent, outside, unaffiliated, completely from the team, like separate person, that athletes can actually travel to us from, you know, around the country, from different states, even from Canada. We do get athletes that come to seek out a second opinion, for example, you know, for their neurologic condition, you know, and to help get an outside opinion that's unbiased. Like I don't get paid by their team. I don't pay for their team. So sometimes that allows the athlete to really have a better relationship with me, and trust me, you know, a little bit more. So, so that's an important role too. So these are some fun videos. I thought for cases, you know, I know it's a case presentation, but I thought we'd go through some examples of mechanisms of head injury. And then we'll kind of go through some examples of different symptom courses, because the main way we actually address concussion and diagnose concussion clinically is by, you know, taking a history, watching videos of hits, and getting an idea of what is the mechanism, and then also what was the symptom course. Did symptoms present in the first 24 hours? Did they start 4 days later? You know, those different scenarios kind of mean something. So this first video, I won't even have to point out to you who we're talking about. They make it very clear, but I want you to watch this video because it is really important. So he got a lot of air, okay, and he went into a seizure. So he's posturing there. They'll show it again a couple of times, and you know, we'll talk about it, but he really gets up there and certainly has to come back down, right? So his helmet comes off. He goes into like a extensor posturing, right, where he stiffens up, extending the arms. So that's a big one. That's a focal, you know, seizure that happens, you know, briefly. So that's definitely one mechanism. And, you know, post-traumatic seizures is not completely uncommon. You know, we do see them a lot, you know, and that's something that obviously you'd want a neurologist to be there for. This video is kind of all about observation. So we really want to observe this athlete. I'll point this one out because it's not so obvious. It's this guy here, number 77. He takes that second hit, and then that kind of ends it for him. He's rolling around. So he's over here. They're all in the huddle still, or you know, in the pile up really. And he's kind of out there. The ref goes over to him. He saw the hit. He stumbles, see that? And shakes his head a little bit, tries to get set back up again. But the ref doesn't like how that looks. And that's a really good referee. That's really what we need to do on the sidelines, is watch every single play. We're not there to, you know, chat with the other docs or chat with whoever. You know, I'm there, I'm standing there, I'm watching every single hit, because that's my examination really. My initial examination of the patient is really what happened with that first, you know, let me play it again, with that initial hit, and how did they respond to it. We get one chance to really look at that. So here's this, takes that second hit really there, and for whatever reason, it doesn't seem like a big hit, but it got him just right. And so the way that he stands up, has to really help himself up, takes a couple steps over there. I mean, that's not right, you know, tries to set back up, and that's it. So that's an important observation that I like to use as an example for everybody. So that's good. So this is another example here. We're going to be watching this player. The hit happens pretty early on in the video, so just keep a close watch on this guy. This was at a Western Michigan University football game that I was on the sidelines at. This is on a kickoff return, which I feel is probably the worst thing, and the worst head injuries come from those, because they're literally running full speed from the whole court, from the whole field down the field to you, you know, so they're really coming at quite a speed. So this is our player here.
Take a look.
You can see that he lowers his head and then swings around, and then he's out. So he kind of bounces off the ground. Even if we look again, this one here, lowers his head, spins around, and he's totally limp, can't even, you know, protect himself at all. Turns out he was limp because, and he had severe neck pain, so they were right, the athletic trainers, to stabilize him. He's moving his arms a little bit now. But what happened was he had such a trauma to the neck that his arms and legs went paralyzed briefly. So he had no feeling and was unable to move them after that contact. So he landed square on his head after the fact because he couldn't use his arms to really protect his head. So so he went and got, I traveled with him to the hospital. We went and got a CAT scan, head and neck, which was clear, but he had a concussion. So this is kind of a good example of what we do on the sidelines and the scenarios that you'd want a neurologist involved. That was me over here on the sidelines with my mentor, Dr. Jeffrey Kutcher. All right, here's another video. I think this is the last one of videos, but so this is a boxer. We're looking at this boxer right here. And they're doing jab for jab, and then the other guy really connects on that. So I don't know if you caught it, but he really gets a 1-2 like that, and then he's out. So he lost consciousness briefly. Then we'll watch as he comes to. You see, he's very dazed. He has this vacant stare, trying to get himself. His arms aren't really coordinating. He falls back over again. He can't get it together in that scenario. So he's still down, and he didn't remember any of this actually either. So he doesn't recall this stuff. So those are some examples of the mechanisms in different settings that we see, neurologic injury from head injury. So just to touch a little bit about concussion, like I said, the classification of concussion, we don't grade them anymore. So what we do is talk about them in terms of how certain we are that that's the diagnosis. Because it's a clinical diagnosis, there's no, at this time, there's no one test that will tell you for sure you're concussed or not. So our classification is possible concussion, probable concussion, and definite concussion. And this was a criteria that came out in the continuum from the AAN in, I believe, 2014. So in any case, the possible concussion is that there's a list of possibilities. Concussion is one of them, but it's not the most likely diagnosis. And certainly there are other mimickers of concussion, things like dehydration or viral illness, having migraine history or going into a migraine, and hyperthermia. These are common mimickers. So there might be a list of these items and concussions on it, but we're not leaning towards it. And then probable concussion is that there's also a list of possibilities, and concussion is the most likely. And then a definite concussion is there's no list, it really is the only explanation. And that's based on, again, mechanism and the symptom course. So we kind of went through some mechanisms. Those were all examples of definite concussions, okay? But in this scenario, now how does this inform how we treat athletes? So with possible concussion, we really treat it situationally because we're not totally sold that it's a concussion, so it depends on what we're leaning towards in that case. And then a probable and definite concussion, we will treat as concussed. So again, they're based on the mechanism and the symptom course. For mechanism, if you have a video available, a lot of high schools now and preparatory schools, they do film, during, their football practices. So I am able to, have the patient pull up the video of what happened, and then we can go over it, because the video is the best, way to really see what happened, how they reacted afterwards. Again, if I can't be on the sidelines, that's the next best thing. And then, is there enough biomechanical force for the brain to have shifted in the skull? That's really the question, because every hit to the head is not a concussion. And I think a lot of providers and a lot of non-neurologists, have really gotten to this knee-jerk, okay, you hit your head, it's concussion, before they say anything else. And you really don't want to mislabel somebody with concussion, because then they're like the concussion kid. And then the next time they have a hit to the head that was not a concussion, oh, they're concussed again, so then we get into this kind of bad pattern, where no one's really thinking about what happened. So we always, as neurologists, we're thinkers, right? So we always want to be doing that. So, we want to see, is it something that could have had the brain shift in the skull? Was it a rotational force? Was it just the repeated injury, the repeated hits to the head, that over time, over a game, by the end of the game, maybe they have a concussion after they've taken a ton of routine hits. But is there enough for it to shift in the skull? One example of a mechanism that for me, I hear a lot about is, people were bent over, then they stood up into like a shelf or something, right? They stood up into something. That's only like a few inches, and if you hit the top of your head squarely, the brain doesn't really shift in an up and down kind of way, right? So you got to think about these things is the point, And so symptom course is the other part. So were symptoms, developed right after, and then last, 5 hours, and then they were done with it, no further symptoms after that? Or did the symptoms develop over time? Like in the first 24 hours or 48 hours, they started having headaches and light sensitivity and, vomiting and sleep problems, and, their mood was off, they were irritable, their appetite went, all different things, right? That's more of an example of a symptom course fitting for concussion. So when we classify them as a possible, probable, or definite, we want to think about these two components mainly to make our best judgment. So let's go over a few, symptom courses, so potential symptom courses. So the first example here, and this is where I want it to be a little interactive. So let me pull up the chat here. Maybe this works better. And then, I see some questions. Okay, so we'll get some questions too. So for this first symptom course, this person, they're all imaginary, but this person had headaches after a hit to the head, and the headache resolved in 12 hours, and they had no further symptoms. They were able to do a full practice that next day, and no symptoms were produced. Were they concussed or not concussed? All right, good. We got a few votes for not concussed. Okay, great. Okay, good. All right, everyone's on a similar page. So let me click this. Okay, so not concussed. That's actually a great example of a traumatic headache. People can, even if they're not like a migraine person or or they don't typically get headaches, the brain doesn't love being hit, right? So, it can trigger a headache for sure, but if the headache really resolves, it's not a big deal. It doesn't last, doesn't cause, no migraine features or anything else. That would be a traumatic headache. So that's good. You guys already knew that, see? Okay, here's another example. So this one, they had a hit to the head. They developed headache with migraine features. They also had sleep problems, nausea, a change in appetite, dizziness, irritability, and these symptoms all lasted longer than 24 hours. So then they were on a stationary bike the next day. This exercise did produce nausea, increased headache immediately. What do you guys think? Concussed, not concussed? Okay, good. Yeah, so, based on just the symptoms, obviously these are not related to the mechanism, but these are definitely a symptom course that would lead to thinking they're concussed, okay? So that's great. All right, here's another example. Okay, so this person sustained multiple low impact hits to the head that did not produce symptoms. So after the game, they developed light sensitivity, headache, neck pain, and this persisted for 48 hours, but then resolved. They also have a notable past medical history of migraines. So are they concussed, not concussed, something else? What do you think? Okay, post-traumatic migraine, that's one, yeah. Stress-triggered migraine, okay, good. See, you guys are already thinking, better than a number of doctors out there, so this is great. Yeah, great, okay, good, these are good answers. All right, so yeah, they're not concussed, and that's a traumatic migraine. So that's really what that is. You don't develop other issues. They have migraine features. If we go back to it, you know, having light sensitivity, neck pain, those are associated migraine symptoms, right? So, so those are good clues. And then always knowing their history is super important. Okay, good. I think this is maybe the last symptom course example. All right, so what about this case? So patient took a hit to the head and they had no symptoms. Then on day 6, they developed headache, light sensitivity, nausea, exercise intolerance. So we're on day 6 when they had symptoms. So what do we think of this? Okay, some thoughts here. No concussion, migraine, post-concussion, concussion, normal migraine. Okay, post-concussion. Okay, interesting. All right, good. Yeah, this one's a tough one. So basically they're not concussed. All right, what happens here is, the point I wanted to make is really that the person took a hit to the head and they had no developed symptoms, but then suddenly on day 6 they have some symptoms. So that the day 6 stuff is not related to the head. Okay, that has to really come within those first 3 days. Any symptoms I hear about, you know, after 3 days, really unrelated. So maybe they have a history of nausea, of migraine, you know, maybe they have, you know, some other explanation, but it cannot be related to the head injury. There's no reason for it to come 6 days later. Okay, cool. All right, let's see here, not concussed. Okay. Now, this is a good, because actually somebody mentioned post-concussion syndrome, so I'm excited about this, because this case is post-concussion syndrome. All right, so we'll talk about what this is, and this is a real case, you know, that I had, and you know, that did well, and you know, we'll talk about some features of this. Okay, so okay, this is a 19-year-old collegiate cheerleader. She was a base. Okay, there's flyers and bases. The bases are the ones holding up people and throwing the flyers in the air, and the flyers, you know, are often, you know, concussions happen a lot, I think, to the bases, but they also happen to the flyers in cheerleading. It's a very, you know, rigorous sport, honestly, as for cheerleading, because tons of concussions happening. I mean, you know, the flyers are landing on the bases, the flyers are landing on the floor, the flyers are, you know, they're causing concussions all around, basically. So, it's a challenge. But basically, with this case, she presented to us for an evaluation of a prolonged syndrome, prolonged symptoms from a definite concussion. So she had a flyer that landed on her head. And that was 1.5 years ago. So when she first came to us, she had already been having symptoms for 1.5 years. I mean, imagine that. Long time, right? She was in college, of course, but she had to leave that semester. It was in the middle of the year, and she had to leave in the semester because of the symptoms. Now, what happened was, when we went over the history and what happened 1.5 years ago, she was instructed repeatedly to rest. So, okay, you know, take a rest for like a month. Then the next person said, okay, you just need more rest. You just need more rest. So she just repeatedly was told to keep resting. And then now it's 1.5 years later, right? So her chief complaints to us were really exercise intolerance. She couldn't tolerate doing even running at all. She was having frequent headaches. They came with migraine features of light sensitivity, nausea. She had increased sleep problems, so she would have to be napping. She said, I just have to be napping. And then she was fatigued when she was awake. And then she also had neck pain. So on exam, we found cervical strain. So we're always screening the neck in concussion cases because of the intimate relationship with the neck, and that the neck can easily be injured as well. And that can be a source of headaches. So we always look for that. So she had cervical strain, convergence insufficiency. So we're always checking eye movements. Convergence is a very important thing to always check for. And it was more than 10 centimeters. You know, anything outside of 6 centimeters is abnormal. And she was like, I couldn't even measure it outside 10 centimeters. But otherwise, the exam was normal. So we did a workout. We did a workout in the office. So I have a stationary bike in my office. And we're always using, you know, we're trying to bring out symptoms so that we can evaluate them clinically. Sometimes people only have symptoms once you exert them. So we have to do that in our office. So we did a post-in-office workout. We did a workout, and then afterwards she had increased nausea and headaches. So it provoked symptoms for her. Then the case, you know, really continues with our plan was start some graduated exertion. You got to start doing something, okay? low intensity cardio, and then progressing from there. And then cervical physical therapy for the neck strain, vestibulo-ocular physical therapy for the convergence issue, and avoid naps, get all sleep at once, melatonin. We try not to use any medications if we don't need them. So it's sometimes a matter of getting their sleep hygiene, headache hygiene. We always talk about, hydration and regular meals and good sleep and physical activity. Those things are really, really important, especially in the post-concussion group, because they just avoided things and avoided things and avoided things, and now they have to really start rehabbing everything. So so this is what our plan was, and then we use Zofran for nausea as needed. So the clinical course really was that she had significant improvement in the first month of physical therapy. We did weekly visits, and she was improving steadily and was able to return to school full time for that next semester. We did use some medication to help her sleep, to get back on track with that. But then she was solid on it. She was able to run a 5K. She decided she didn't want to return to cheerleading. That was her choice. But she ran 5K and was exercising as much as she wanted to without problems. And ultimately she tapered off her medication completely. So we only use the medication temporarily. Once you feel 100%, then we can back off and taper slowly off things. So she had been 100% for a few months, so then we went off it, and she stayed off it and continues to live her life fully. So with that, those are my cases and examples. Let me go back to the chat and try and do some of these questions I saw along the way. So let's see. Okay, so what kind of clinical research do sports neurologists do aside from concussion and recovery? Great question. Okay, we do a lot of biomarkers. That's a big one. There's a lot of research going into like different neuroimaging techniques, functional MRI, quantitative EEG. There's all kinds of stuff going on for clinical research with that. Also, we do a number of, longitudinal studies. There's even a study I was in when I was in fellowship that was longitudinal, going on for many years, but looking at helmet sensors, and if those were helpful or not, and we would reevaluate the concussed kids, and really trying to evaluate these different devices. So that's a big deal for even identifying concussion. But really anything you can think of, we need more information about, so concussion is a big one, but certainly, peripheral injuries, peripheral nerve injuries, brachial plexus injuries. I wrote up a case, that I had of identical twins, and I presented that as a poster at the AAN during my fellowship. So I had identical twins that were both concussed at the same time. It was kind of this crazy thing. So if you have interesting cases like that, that can give us information for the larger community. So clinical research is really endless. But yeah, it doesn't have to be concussion. It can be, just post-concussion syndrome, getting people back, different techniques, how to use your exercise, that kind of stuff. Anything goes really right now because we just need information. Good question. In a possible concussion scenario, was the injury or event precipitating the symptoms not observed? So in a possible concussion, it can be that they are related to the injury, okay? But it doesn't have to be. So like sometimes there's a case where a kid has a history of migraines, let's say, then they take a hit and then their migraine is really bad, or maybe they just had a dull headache beforehand and now the injury has made it go into full-blown migraine, so head injuries definitely produce symptoms. Now in possible concussions, it's not enough to say that they were concussion. Maybe if their only scenario is that they only have headaches, then that's less likely. So the symptom course, like we were talking about, kind of matters with all of that too. I don't know if that answered that question, but I tried. Okay, let's see. Then we went through a bunch of these things. Okay, we did our cases. What could be other differentials? Oh geez, I don't know which case that was related to. Well, I mean, like I said, the other differentials really are, let me see if I can get back to that slide. know, that there's common mimickers really. So things like dehydration, viral illness, migraines, hyperthermia, you know, you really want to think about the whole scenario. What kind of conditions was that athlete under when they took the hit? You know, did they drink enough water that day? You know, did they eat 3 meals? Maybe they didn't have a meal. Maybe their blood pressure was low. You know, you got to put the whole kind of picture together. And as neurologists, this is like what we do on a regular basis, because we mainly are, I think of it as we're like little Sherlock Holmes. You know what I mean? We all kind of have to, you know, put the whole scenario together. Patients come to us with these unique symptoms that they're like, I know I sound crazy, but actually to the neurologist, that's not crazy at all. You know, we can make sense of that kind of stuff. So that's one of the things about neurology and being a neurologist is really that, you know, we can make sense of a lot of stuff because we think about it. And a lot of other physicians don't do that. And, you know, maybe they don't have the time, whatever the reason, but, you know, we're able to really do that. And so that's kind of fun for us. Let me see if there's any other questions here. Some questions, I know we talked about that. Okay, how can I find sports neuro-related research to get involved in? Good question. So sports neurology, like I said, it's a very small field right now. In the country, there's right now, I believe, only 9 fellowships that are available. So at Hartford Healthcare, I am adding my program to the list of fellowships starting in 2022. Hopefully, that's our plan, so that we're getting more fellowships in the country every year. But I would say, you know, if you're near a place that has sports neurology or a neurologist that sees a lot of sports, maybe they're not fellowship trained, but, you know, they do some research. Any institution usually has some sort of concussion related research or sports neuro research. So I would reach out to, you know, like here, we have University of Connecticut, we have Hartford Healthcare, you know, so there's groups doing concussion research pretty much at any major university. I would think there's somebody doing that. So, but I would say probably either at the collegiate level or higher. But so I would start at those kinds of places, but it may be hard to find. I'm not sure, Genevieve or Maggie, if the AAN maybe has a compilation of what research is going on. I'm not sure, but that might be a resource also. Let's see, is there a role for sports neurologists in working with athletes to improve focus and performance? Yes, so improving performance is a huge deal. You know, sometimes we get athletes who have migraines, they're suffering with their migraines, they cannot get them under control, you know, and we have to be really thoughtful about what medications to use, right? Because, you know, beta blockers and stuff like that, you can't use that for athletes, right? They have to be getting their heart rate up in their, you know, you can't, you know, basically restrict their blood pressure. You know, you can't use certain things if they're going to be performing at an athletic level at least. So that's absolutely what we do, you know. But even just, you know, managing people who have a history of concussion, they want to be monitored long-term if they want to continue playing their sport. We do a lot of that also, and just a lot of education, you know, going out into different communities, to parents, to, you know, schools, everywhere. We really talk to anybody. And I give a lot of grand rounds at different institutions. So, you know, there's tons of you know, work that we do in improving focus and performance. Focus is a big one because, you know, attention deficit disorder is certainly a comorbidity of concussion in terms of, you know, it can really complicate the picture if an athlete has ADD or ADHD or even pre-existing anxiety or some of these other, you know, mood disorders in addition to the attention issue. After a head injury, those things get amplified, you know, so then we have to really work on maximizing that athlete or that patient from, you know, the whole kind of perspective from all of their symptoms. What do you think of eye tracking device for concussion evaluations? So good question. Eye tracking devices are interesting. I have used them before, you know, kind of as a, let me try this out kind of thing. I don't find that they're terribly more helpful than the neurologic exam. Because as neurologists, you know, we're able to really keenly do our neuro exam of the eye movements. What I prefer to do is a clinical evaluation of what's called the vestibulo-ocular motor screening, or the VOMS or VOMS test. That's a really common concussion evaluation that we have now. Super helpful. Convergence insufficiency is actually one of those things that we look at as one of the components of that test. But I've seen devices, I've used devices just to try them and see if they would be helpful, but most of the time I'm not surprised by what they find based on my exam. So I don't think we're there yet. And, you know, for me, I'm really not a proponent of computerized or standardized kind of testing like that because it takes the thinking out of it. And, you know, there's always going to be normal variance to eye movements. You know, some people have one pupil bigger than another. Some people get nystagmus, you know, and gaze. You know, does it account for those things? You know, as a neurologist, we know what's within the realm of normal and what isn't, more than a computer would. So it kind of takes the thinking out of it, which I think can be a little dangerous. And, you know, as part of the AAN's guidelines for concussion is really that we want to never use a tool by itself. We always have to use these other assessments or other tools, including like impact testing or some of these other tests, computerized tests, in addition to a clinical evaluation, because it's a clinical diagnosis. So that's a great question. Is there any kind of follow-up for patients who have had repeated concussion injuries, such as like biomarkers? Good question. So these are great questions. Okay, good. So basically for follow-up of patients with prior, like multiple prior head injuries, let's say like a retired professional football player, right? They have like thousands of injuries, okay? Depending on how many years they play, but you know, thousands of injuries, let's say. So what I like to do initially is an MRI of the brain. I like to look even deeper than like your standard MRI. We do like what's called diffusion tensor imaging, or DTI, looking at the different tracks. We like to look at susceptibility weighted images, looking for microhemorrhages or evidence of shearing from the axons, you know, things that would leave a mark from long time, you know, use and over, you know, multiple injuries. So I like to do things like that to evaluate them initially, maybe some neuropsychology testing. I put them through neuropsychometric testing to get a really in-depth view of their executive functioning. But as far as biomarkers go, they're all purely research at this point. There's no biomarker that we say you need to do, or we could write you a script for, or something like that. You know, they're not commercially, you know, available. They're not widely available right now. So there's definitely tons of research going on in biomarkers, but there isn't one thing that I would say, you know, we have that we could say, that we could point to say, you know, that these are, you know, repeated injuries, what types of things we can track. So I still use neuropsychology testing. That's something that we can repeat on a yearly basis, you know, and you can always track MRI changes, but more important is actually the history and physical. So if you do an annual history and physical neurologically of that person, you're going to be watching any new symptoms come into play, any you know, development of dementia, anything like that. And those are all treatable things, you know, so so that's really what I would say I rely on more, because we just don't have those available yet. Do I see pediatric athletes as well? Yeah. So I see ages 6 and up. I'm an adult neurologist by training. I did my residency in adult neurology, not child neurology, although there are sports neurologists who are child neurologists in their residency training. So for me, because of my fellowship, which was, you know, youth level and up for athletes, I can see ages 6 and up. How often during a game generally does a possible injury occur that you evaluate? Good question. So on the sidelines, I did, this past year I was at UConn, so for football, and you know, even in my years of Western Michigan University and other teams, it's very hit or miss. I tend to be kind of a white cloud, so we call that a white cloud when nothing really happens. So it's funny, some days you get something, but most days you don't. You know, there's a lot of games that there's really no head injury, you know, there's games where they're back to back to back, you know, maybe every kickoff return there's somebody going down, you know. It's very hit or miss, but I for some reason tend to be a bit of a white cloud in that way. So But sometimes, you know, what we like to look at too is, you know, are we playing a very good team, you know, or like a high level team and we're kind of a lower team, you know, if that matchup is off, you know, we get a little worried, like, okay, there might be some injuries, you know what I mean? So it's kind of interesting in that way. You know, and actually as the, you know, physician on the sidelines, we're the physician for both teams. So I still am an unbiased, you know, person. I'm just there for any neurologic concern, you know. I'm not clapping for whatever team I'm with because I just am there to make sure everybody stays safe is really my role. So let's see. Are patients with history of migraines more susceptible to concussion? Good question. So we don't really know if they're more susceptible to getting concussion, but what really the point here is if you're a migrainer, then you're more likely to be diagnosed with a concussion, if you see what I'm saying. Because concussion, like I said, migraines are a mimicker of concussion. So if you took a hit to the head and you go into your migraine and people aren't thinking about it, you're concussed, okay? But maybe you're not really concussed. So that's where the nuance of what we do is really important, because it's easy to just say, yes, you're concussed, rather than you have migraines, you know? Maybe they're not diagnosed yet. Maybe it's in a child who hasn't ever really had a migraine before, but now they went into this traumatic migraine or something like that. And it's just their first migraine that was in the setting of a trauma, you know? So it's a bit of a nuance there with what we do compared to what other providers do. How does migraine management change for professional athletes? Okay, good question. So kind of what I was alluding to before, that, you know, we want to pick our medications carefully because, you know, if someone's in what we call status migrainosis or a migraine that's going on for 3 days, right, more than 3 days, we would normally use something like prednisone, okay, like a course of a steroid or something to really abort that intractable migraine. But if you do that, then, you know, with a professional athlete, you have to fill out, you know, the therapeutic use exemption form, you know, so there's a lot of things to think about that maybe the general practitioner wouldn't know about dealing with athletes. So we would just have to be choosy about our medications, things that wouldn't necessarily, you know, make them drowsy, right? I wouldn't want to use something that would make them drowsy. I wouldn't necessarily want to use something that makes them gain weight, you know what I mean? Or, you know, we really want to be thoughtful about what we're choosing. Whereas, you know, we all know what's a first line, second line, you know, third line medication as neurologists, but, you know, maybe the first line isn't our first choice for an athlete. So it's things like that that kind of make what we do pretty interesting. You have to get kind of creative, you know. What do you think about the efficacy of the ketogenic diet in post-TBI concussed patients? Great question. There's a lot of, you know, I get this question a lot. I get a lot about ketogenic diet and I get a lot about intermittent fasting. Now, intermittent fasting, just to put that to bed, is I always discourage it in patients who are certainly concussed or dealing with post-concussion syndrome because the brain likes a routine. It wants to get morning, noon, and night every single day. It does not like long periods of fasting, you know? So if you're trying to recover from something, you don't want to be doing fasting periods. So that's one thing. Ketogenic diet, you know, we do know in neurology, especially in epilepsy, it's very widely researched, especially in pediatric epilepsy, that, you know, the brain uses ketones well. So, you know, they have ketogenic diet as like treatments for epilepsy and certain refractory epilepsies. I don't have strong evidence that everybody needs to be on it. There is, you know, anecdotal yes or no or whatever. So diet-wise, you know, we talk a lot about, you know, omega-3s, that kind of thing, maybe promoting that. But again, there's no research that's out there that says definitively, you know, from a randomized control trial that people need to be on ketogenic diet. So if we're going by evidence-based, I don't recommend it. So if patients are doing that and they've been doing it for years and that's their way of life, then I figure, okay, that brain's probably used to it. So, you know, it may be okay, but I just don't have enough evidence or research on my end to tell patients that you need to be on this kind of diet. Do I treat patients with suspected CTE? Awesome, awesome question. I was hoping we would get a CTE question actually. So interesting. So CTE, I could talk forever about CTE. CTE is actually obviously it's a post-mortem diagnosis. So it's not something we can diagnose in a living person. So you're right to say suspected CTE because that would never be confirmed in a living person. That's the first point. Now, there's a lot of research and papers and such that says, oh, symptoms of CTE are, I don't know, memory changes, aggression, suicidality, that kind of stuff, right? But we can't say that those are symptoms. There's no diagnostic criteria in a living person. So it's a pet peeve of mine actually that patients come to me with questions about CTE and do I have CTE? And it's like, okay, I can't tell you that. We don't know, and it actually doesn't matter, right? Because if they're seeking care and they come to us with memory problems, anxiety, depression, cognitive concerns, all this kind of stuff, then we can address those. Concerns. So that's the main thing. Those are treatable symptoms. So I don't know if they'll have CTE or not when I'm treating them, right? But I definitely treat patients with psychiatric concerns, especially in the setting of multiple head traumas. I definitely treat those kinds of patients, and all sports neurologists do. Are there non-contact sports that are high risk for TBI concussion? Good question. Honestly, I do feel like there are a lot of athletes, a lot of sports that cause concussion. Like I said, cheerleading, okay, that's not really considered a contact sport, but there's tons of contact there. Volleyball, soccer, baseball even. None of those are considered contact sports, but there's contact at times, and it's pretty bad when it happens, So I would say any of those are a big deal. When it happens, it happens. So, but that can definitely come from non-contact sports. But those are just to name a few. Soccer is probably the #1 for girls, concussions in girls at the youth and high school level. Basketball, of course, as well, that kind of thing. So there's definitely those. All right. Let's see, anything else? Do sports neurologists treat epidural hematomas secondary to skull fracture, or is that more for vascular neurologists? Good question. So epidural hematomas, so we always want to prevent that from happening, right? But, so some sports that are at risk for that are things like boxing and football and ice hockey, right? So that's why those people, you typically wear, helmets to prevent skull fractures, okay? Or to prevent strong trauma, to the temples that can produce an epidural hematoma. So in that setting, actually a neurosurgeon is the person to evacuate the blood. They go in the skull, they fix all of that. That would be up to a neurosurgeon, actually. Vascular neurologist is more along the lines of, stroke or venous malformations in the brain, bleeding from that. But neurosurgeons, because it's so critical and, really scary, and from high trauma, that's who would handle that. What other cases do you get anything non-sports? Oh, I mean, as a neurologist, we get all kinds of things. So, I see car accidents. I see, because I do treat people who have had a car accident, but also like to live, actively. So they want to be, they're a marathon runner or whatever, but they happen to be in a car accident. The brain doesn't know the difference between what hit it. So the treatment is really similar. So I definitely get cases that are non-sports related from their injury, work-related injuries, things like that. Surgery involved, we hope not, right? We never want a case that has surgery involved. But certainly I do find a lot of, because we get a lot of patients with neck pain as a comorbidity. Let me turn off the screen so I can maybe see you all. Okay, good. So we often get cases, that have neck strain or neck related issues. And so I do an MRI of the cervical spine, for example. Maybe we find a compression, maybe we find, a nerve root that's impinged. Maybe it requires an EMG test. And then maybe that requires a surgery, So Other procedures that I do, so I don't do surgery, but other procedures that I do are trigger point injections for neck spasm. I do occipital nerve blocks because occipital neuralgia is another big condition that we get even just from like direct contact to the back of the head where those nerves are. You can do those nerve block procedures. So those are just to kind of name a few. All right, let me see here. Epidural hematoma we talked about. Okay, other cases, non-sport. And do I get to be a part of it? So I'm a part of it in the sense that I would be referring the athlete there. I'm still their main sports neurologist, but I collaborate and I, ask for, I send referrals to people as I need them. If I need a psychiatrist, if I can't manage their mental health condition, then, that would be the other thing too. 5-minute warning was a while ago, so let me see here. Do you work closely with sports psychologists? Yes, sports psychology is another group that we work with closely. Again, because anxiety is very high, they're under high stress. So that's always a comorbidity that we're dealing with. Some people get PTSD and that, they have a hard time getting back to their sport because of that limiting it. They're just fearful after whatever happened that it may happen again. It may end their career, and that's a lot of stress on that type of scenario. What are some, wait, hang on. Do we help with coping with their diagnosis? Yeah, we use that. What are some good sport neurology clinical insights for general practitioners? Well, I think there's a lot of clinical pearls, for general practitioners. I give a lot of talks to, PAs, APRNs. I give a lot of talks to, urgent care. I give a lot of talks to primary care doctors and such too. But I would say, just keeping in mind and really think about what happened. Is it a concussion or maybe is it something else? I think that's probably the main thing. And to always do history and physical examination and never substitute that with, a device or a computerized test or something like that, because that's where you get into problems and misdiagnosis. Let me see, anything else? How is the training for nerve block? Oh, nerve block injections, super easy. If you do 3 or 4 on a rotation with me, you're certified. So it's pretty easy. They actually have the American Headache Society they usually put on a conference annually that also you can do training with them, and they'll go over how to do Botox for migraine. You can learn quite a bit, but they'll also touch on occipital nerve blocks too. So the training's super easy. You don't need to do too much. You don't need to know too much. Just know your landmarks, and it just goes right under the skin. Super, super quick and easy, and really gratifying as a neurologist, because it's something I can do that makes them instantly better. They walk out of my office 100%, no pain, everybody's happy. So that's my favorite thing to do probably for patients. Okay, great. How often am I on the sidelines versus in clinic? So in clinic for me, I'm on 4 days a week in the office myself. My 5th day, like Fridays, are for things like this. On the sidelines, certainly more during football season, but on a weekly basis, I'll be on some sideline somewhere. So football's a big one. We may do some, different contests, like I said, boxing, MMA, that can come at any time of the year. There's no real season for that. So we're available for that. So it kind of is on the fly, which makes it really interesting for me. I feel like, I can kind of do what I want here and there, different settings. I'm not always in the office. I'm not always, on the sidelines. It's a good mix for what I like to do. So, all right, let me see. I think that's all the questions. Gosh, I hope I didn't miss one. I was trying to go through them all. So, all right, I guess that's it. Any other questions or anything? I think I put up my information with my email, so feel free to reach out.
Yes, thank you again so much. I know I learned something, and I'm not in medical school, so thank you so much. I did link a quick survey in the chat so we can give some awesome feedback. Feel free to thank Dr. Alessi-LaRosa for her time on this beautiful Friday. And we will be hosting more of these throughout the rest of the year, so stay tuned for that on the Medical Student Synapse. And reach out to me if you have any questions. Thank you all.
Okay, great. Thanks, guys.